Good afternoon, everybody. Until the time that Dr. Saab joins us for acting as the chair for this session, may I welcome you all to the JSS. As you all know, it's an effort started by Professor uh, B.K. Kapoor to cater to middle and low income countries, uh, concentrating on knowledge transfer and benefiting everybody. So, I welcome everyone to this session. I'm Dr. Rajendra Desai. I work in Hyderabad, but I'm a past student of Dr. V.K. Kapoor, so I'm pretty happy that he has started this initiative.
Hi, Dr. Desai, thank you very much. I think Dr. Deepak has not joined, but we can start it now. If you allow me to start, please.
Uh, well, it would be better if you could ask whether Anand is online because Anand usually moderates. Piyush Varshney usually moderates the session. I can't see him either. But given that we have a time constraint, it's 5 minutes. I welcome you now, sir, to start your talk. You'll be talking to us on surgery in pancreatic cancer.
Yes. I think we will
Doctor,
start because just for the interest of the delegates, because I think the initial time conveyed was 2:30. Many of them have joined at 2:30 actually.
oh,
So
really?
should we start?
Yes, please, do start.
Yes. So, so I was asked by Professor Kapoor to keep it slightly simple and informal in the sense that the delegate should be allowed to ask questions and it should be more a theoretical discussion with practical tips later and a discussion should be more postgraduate student oriented. So I'll try to keep it that way. Uh, I'll try to cover most of the topics one by one, irrespective of the slides. Most of my slides may be slightly focused towards borderline resectable tumors or locally advanced tumors, but I will ensure that most of the postgraduate student interest topics are covered. If I miss something, I think Dr. Desai, in the end, we can just ask them to ask few topics if they want clarity on
Yeah,
that, and that's how we will cover this session.
they
So
will.
we
They
all know that.
usually post questions on the chat, and we can answer them at the
Yes.
end.
Yes, so I think I will try to spend more time on that section rather than the PPT and the presentation because I think clearing the doubts is more important. So we all know that pancreatic cancer is a cancer with a dismal prognosis. The 5 year survival was previously around 5 to 6%. It has been increased in last 2 to 3 decades gradually with advancement in surgery, advancements in chemotherapy, and maybe better perioperative care in the post-operative period. However, we are far from the what we expect and what progress has happened in last 2 to 3 decades in other cancers. But improvement of around 5% in 5 year survival is what we have achieved in this cancer. India is among the low incidence areas for pancreatic cancer in the world. Having said that, sheer numbers of pancreatic cancer patients in this country because of a high volume, high population is significant, and and we still cater to a large burden of pancreatic cancer in our country. We all know that surgical resection is the only chance for cure for pancreatic cancer. Uh, in few patients, there has been a study. We are aware of an NEGM study where surgery with adjuvant FOLFIRINOX with R0 resection in that subgroup, uh, survival as high as 54 months median has been achieved in pancreatic cancer. But that is a very select subgroup of patients who undergo R0 resection and complete their adjuvant chemotherapy with a regimen like FOLFIRINOX. So for all comers, the survival in pancreatic cancer for 5 years is around 8%. For patients who undergo a successful R0 surgery and complete their adjuvant chemotherapy or neoadjuvant chemotherapy with FOLFIRINOX, they can achieve a median survival as high as 54 months. So that is the extreme difference in outcome in pancreatic cancer patients depending upon the type of treatment they receive. And we all know that as similar to other solid cancers, early detection and treatment is of paramount importance for this cancer. Uh, most of the students are aware of the clinical presentation of pancreatic cancer. Just for clarity, most head pancreatic cancers will present with jaundice. Some of them may present with associated cholangitis, pruritus, weight loss, or a loss of appetite would be there. There is a slight difference in patients who present with a pancreatic head cancer and some patients who present with a pancreatic body tail cancer. The main difference would be jaundice. Loss of appetite and weight loss is more uh, uh, prominent in the body tail cancers, and jaundice and obstructive jaundice and the features of obstructive jaundice are more prominent in pancreatic head cancers. Having said that, the symptoms of advanced cancers are similar in both types, where patients can develop supraclavicular lymph nodes or they can have free fluid in their abdomen. So there is somewhat difference in the presentation of right-sided, that is the head of pancreas cancer, and left-sided, that is body tail or neck cancer, where the difference is predominantly in absence of jaundice. Loss of appetite and loss of weight is more prominent in body tail cancers. Similarly, because of the less symptoms in early phase or non-specific symptoms in early phase, many patients with body tail pancreatic cancers present with metastatic disease at presentation. So chances of metastatic presentation is higher with patients with body tail pancreatic cancer. Having said that, coming to the, uh, I think to the cross-sectional imaging. So the most favored cross-sectional imaging for pancreatic cancer we know is a cross-section is a contrast enhanced CT scan. In the context of known case of pancreatic cancer evaluation, a triple phase pancreatic protocol CT scan is what we want to do. A pancreatic protocol CT scan is a very unique CT scan. Let me see if I have a slide which describes the definition of a pancreatic protocol CT scan. So pancreatic protocol CT scan essentially involves three phases, which is the early arterial phase, which is predominantly used to is it visible? Am I audible?
Yes, sir.
Yes.
Yes, you're audible,
Okay.
sir. And
Okay.
also slides are
Okay.
visible, but the print is appearing too small. I don't know whether it's full screen or not.
Okay. I'll just try to make it full screen. Is it fine?
It hasn't changed much.
Okay. It is probably this the image quality
Bloom,
is not
sir.
good. Okay. So
Image
pancreatic
quality is
protocol.
good.
Okay. This slide ka image quality I'm saying. My slide may be little inferior. Okay. So coming back to the pancreatic protocol CT scan, it should preferably be a 64 multi-detector rows scanner. Uh, Thinnest possible. Previously, less than 5 millimeter qualifies as a pancreatic protocol CT scan, but preferably the cut should be as small as 1 millimeter. And negative oral contrast is what we use it in that. Even a plain water is fine, but you cannot use a positive oral contrast because you want to see the pancreas and the vasculature more predominantly, and it's a focus scan. The IV contrast rate and speed is defined for this. The contrast is usually slightly is given at a rate of 3 to 5 ml per second, and minimum 120 ml contrast is used for pancreatic protocol CT scan. So it's a very unique type of CT scan, and similar type of MR is used, and which is called as a pancreatic protocol MRI scan. But the most important and the most preferred is the pancreatic protocol CT scan, which will give you with these kind of images an early arterial phase, which is used to define the anatomical variations in the vasculature around the pancreatic tumor, and the arterial phase, which will help you to identify the pancreatic primary. Usually, the pancreatic cancer is hypoenhancing as compared to the rest of the pancreatic parenchyma, and other tumors of the pancreas, like a pancreatic neuroendocrine tumor, is hyperenhancing as compared to rest of the pancreas. So these are the enhancement patterns which help us to distinguish between different types of pancreatic tumors. A venous phase will allow you to look for the uh, vascular abutment of the pancreatic tumors. Very frequently, the pancreatic tumors have borderline resectable or locally advanced radiologic features, and that's why arterial and venous associations between the SMA and celiac and its branches, and portal vein and supramesenteric vein and splenic vein is very important, and that all is served by this classic pancreatic protocol CT scan. In this particular patient, if you see the scan, you can see in the second image a hyper-enhancing uh, lesion in the pancreatic head, which probably is completely encasing the uh, which is probably completely encasing the supramesenteric vein, and you can see the splenic vein which is going away. So this is probably a case of borderline resectable pancreatic cancer, and we will go back to that part in some time. Uh, After that, coming to the role of preoperative biliary drainage for pancreatic cancer. So patients with pancreatic head cancer who present with obstructive jaundice, there is always a discussion of preoperative biliary drainage, whether it should be done routinely or should we not do it, who are the patients in which it should be offered. So generally, there is no predefined criteria for biliary drainage as far as the levels of bilirubin are concerned. However, bilirubin levels above 15, it is generally associated malnutrition and associated liver dysfunction are such that many centers follow a cutoff of around 15 grams per liter or of bilirubin levels. However, as such, if you ask me, in literature, there is no cutoff and there is no predefined level of bilirubin at which you should be doing a elective preoperative biliary drainage before going ahead with a pancreatic duodenectomy. If the patient of jaundice has associated malnutrition, even at lower bilirubin levels, that can become an indication of preoperative biliary drainage in that particular patient. And if the patient is in a extremely fit, good performance status, that patient, if he doesn't have any major hepatic dysfunction or coagulopathy or malnutrition associated with jaundice, that patient can undergo surgery even above bilirubin level of 15. So there is no clear cutoff as far as the jaundice is concerned or the level of bilirubin is concerned. The patient's liver dysfunction, apart from bilirubin levels, coagulopathy, become a lot of patients with pancreatic cancer or duodenal tumors will have a partial. Am I audible?
It's going off in between.
I'll just check
Please
my
continue.
internet
Let us hear.
connection. Okay, so a significant proportion of patients with pancreatic cancer and duodenal cancer may have um, partial gastric outlet obstruction, and ERCP may not be feasible in these patients. Endoscopic ultrasound guided biliary drainage or antegrade stenting are few other options which can be exercised if ERCP guided stenting is not feasible. If endoscopic ultrasound guided drainage is also not feasible, probably percutaneous transhepatic biliary drainage also can be performed. But having said that, 90 to 95% of the patients who need preoperative biliary drainage most of the times undergo successful ERCP guided stent placement. As far as the choice of stent is concerned, uh, uh, the plastic stents have a tendency to get blocked in a short period of time of few weeks. So if you are planning the patient for a neoadjuvant therapy, or if the patient has a history of cholangitis, or if the patient has a significant malnutrition, which probably going to prolong the wait list, prolong the time to surgery. These are the patients where you probably need to consider use of short SEMS or a short covered self-expanding metal stent or a plastic stent. At least at Tata Memorial, our preferred stent for patients who need preoperative bed drainage in pancreatic cancer has been short SIMS, and the results with short SIMS are better as compared to plastic SIMS. Obviously, there are cost concerns which you should be concerned about. If there are no cost concerns, the preferred stent which does better in preoperative will drainage is a short self-expanding metal stent. There is an evidence. So for postgraduate students, the indications for biliary drainage can be divided into selective or relative indications, or soft indications and absolute indications. Obviously, the cholangitis, presence of coagulopathy, malnutrition, and neoadjuvant therapy are absolute indications. The softer indications may not be theoretically important. However, a few centers do use bilirubin level more than 15 as a cutoff, even in asymptomatic patients. Uh, Everybody must be aware of this drop trial, uh, but I think for postgraduates, the trials are not important. The principles are important. Um and this is a classic example of another patient who had a borderline resectable pancreatic cancer. But I think we'll go to that part. Coming to the role of biopsy. A role of biopsy in pancreatic cancer is usually debated. As far as if the patient has a jaundice and if the patient's cross-sectional imaging documents a lesion in the pancreatic head or periampullary lesions, most of the times we do not need a biopsy. If you are not planning for preoperative biliary drainage, usually if the lesion is documented on a CT scan, in a patient with a documented lesion, there is no need for doing an additional evaluation for only for the sake of biopsy. Having said that, many ampullary lesions are very small, and most of the pancreatic tumors are borderline resectable or locally advanced. And many of these patients do need preoperative biopsy. In case you only need a lesion documentation, if the lesion is not clearly seen on cross-sectional imaging, these are the patient probably where you need to perform a side view endoscopy to document the lesion. And if the lesion is also not visible on side view endoscopy, that is probably the indication for endoscopic ultrasound in the patients with pancreatic cancer. So for postgraduates, the side view endoscopy, endoscopic ultrasound, and endoscopic ultrasound FNAB. Currently, the FNAC has been replaced by FNAB in tumor evaluations for pancreatic cancer. The needle which is used for biopsy is now larger, and you can get larger tissues. And therefore, side view endoscopy, endoscopic ultrasound, and FNAB are the investigations which are to be done selectively in these patients. Coming to the role of tumor markers, I think we know that the CA19-9, that is the carbohydrate antigen 19-9, and CEA are the two major tumor markers in the context of pancreatic and periampullary tumors. Most of the patients, around 70 to 80% of the patients with pancreatic cancer will have raised CA19-9. We must know that CA19-9 levels are increased even in few benign conditions like chronic pancreatitis, acute pancreatitis, or any or pancreatitis of any cause. So any pancreatic inflammation or pancreatic ductal block will result in rise in CA19-9. Similarly, CA19-9 levels may be inordinately raised as compared to the actual values if the patient has obstructive jaundice, and therefore in such patients you need to use normalized CA19-9 values which are proportionate to the bilirubin level of the patient, and probably a post-operative, probably a pre-operative values or a post-drainage values are more important in the patients with obstructive jaundice. CA19-9 is considered raised if it is raised more than 3 times the upper limit of the institutional value, which is usually around 37 units per ml. So if it is more than 100, it has a clinical significance and it should be looked into. Having said that, the levels of CA19-9 may be normal in patients who are Lewis antigen negative, which is around 10% of the general population. 90% of the patients with tumors will have raised CA19-9 levels. In pancreatic cancer, CA19-9 levels in thousands are usually indicative of advanced disease. There have been studies from multiple centers from India. I think there is a study from KM, and also I think there is a study from H. Ramesh, Dr. Professor Ramesh's group, where they have shown that CA19- level more than 4,000 in non-jaundice patients are predictive of metastatic disease. So CA19-level does not have diagnostic value. However, in a patient of a proven pancreatic or a periampullary cancer, it definitely has a prognostic value. So that's the significance of tumor marker in these patients. Finally, coming to the borderline resectable and resectable and locally advanced subgroup, you can see that around 15 to 20% of the pancreatic cancers are resectable at presentation, and general outcome is for patients who undergo successful resection and complete adjuvant therapy. You can see that the median survival historically have been around 2 to 3 years, but in PRODIS trial with adjuvant FOLFIRINOX, the survival has recently increased. So in R0 patients who undergo a curative intent resection, the median survival in pancreatic cancer patients is around 2 to 3 years. Is what the current values are. So the patients are divided into resectable, borderline resectable, locally advanced, and metastatic. So around 10 to 20% patients are resectable. Around 30 to 40% patients are either borderline resectable or locally advanced, and 50 to 60% of the pancreatic cancer patients are metastatic on presentation. So let's go to the definition of borderline resectability. So anatomically, am I audible? Hello.
Yes, you are, sir.
Yes. Okay. So anatomically, so as around 40 to 50% of the patients with pancreatic cancers are either borderline resectable or locally advanced. The borderline resectable and locally advanced tumors becomes a very important subgroup to look into, and a proper definition of this subgroup is very important. So most of the associations across the world, like NCCN, AHPBA, SSO, have put forward their definitions. But the gist of the definition lies with either a venous or an arterial criteria. So for all practical purposes, a venous involvement, which is reconstructible, is defined as borderline resectable, and arterial involvement, uh, which probably makes it inoperable, is considered as locally advanced disease. So these are the practical definitions. However, you should know the actual definition of NCCN given by NCCN in the context of venous and arterial criteria. So a venous contact more than 180 or complete block of the vein, as long as the venous contact is reconstructible, is defined as a borderline resectable pancreatic cancer. As far as the arterial contacts are concerned, no contact with the artery is defined as a resectable pancreatic cancer. A contact which is less than 180 is defined as borderline resectable pancreatic cancer, and a contact which is more than 180 or a complete involvement or encasement is defined as a locally advanced pancreatic cancer. So, so these are the arterial and venous criteria for pancreatic cancer for borderline resectability and local advancement. Only exception is now the celiac artery involvement, which is feasible for distal pancreatectomy with celiac artery resection after adequate neoadjuvant therapy, that is called as DPCAR or modified Appleby procedure. That is probably now option, and it has been included into borderline resectability. It was previously included in locally advanced pancreatic cancer. So these are the images where you can see that these are the three types of tumors. You can see the first image where the head tumor, you can see the stent, you can see the mass, and there is a completely black plane of fat between the artery and the vein and the tumor. So this is the example of a resectable pancreatic cancer. In the second image, you can see the superior mesenteric vein is almost near completely involved. However, the plane with the SMA is still clear, and therefore it is a borderline resectable pancreatic cancer. In third image, you can see that the SMA has been completely encased. Also, the lamina with the aorta seems to be obscured for some length, and therefore this is a case of a locally advanced pancreatic cancer. And these are the definitions of borderline resectability and as far as the radiological criteria is concerned. However, International Study Group of Pancreatic Surgery in 2018, 14 first proposed these criteria. These criteria are only radiological. So if the patient's performance status is not good, even if the patient has a resectable pancreatic cancer, that patient is probably not going to complete the full treatment, and their outcome may be similar to borderline resectable or locally advanced pancreatic cancer. Similarly, if the patient's CA19-9 or tumor marker is significantly raised, which is in the context of borderline resectability is defined as more than 500. So if the patient's performance status is not good, or if the patient's CA19-9 level is more than 500, these patients still behave like borderline resectable pancreatic cancers or locally advanced patients, even if they are radiologically resectable. So giving points to the biologic and conditional factors, some of the resectable tumors can still be subclassified into borderline resectability, and therefore, along with anatomical criteria, biological factors and conditional factors have also been added to the definition of borderline resectability. So this is a recent change. There are also the criteria of duodenal involvement and the tumor extent in relation to the duodenum, and the criteria where the first jejunal vein involvement is also considered to define the borderline resective and locally advanced tumors. However, that has not been clearly accepted in routine practice among the clinicians, and therefore, probably with postgraduates, we do not need to discuss that. So I think by now we have covered the uh, CT scan, preoperative bile drainage, role of biopsy, tumor markers, and definition of borderline and locally advanced pancreatic cancer. Uh, Now coming to the surgical technique. So just a minute. So because the outcomes with patients with pancreatic cancers have been traditionally poor, in spite of the improvement in systemic therapy, in spite of the improvement in surgical technique in last few decades, the results as compared to other solid organs still remain poor. And therefore, pancreatic cancer is considered a systemic disease. Probably the dissemination of the metastatic cell starts very early in the pancreatic cancer. Even small tumors exhibit micrometastasis at initial stages, and therefore the idea of neoadjuvant therapy is entertained in pancreatic cancer. Neoadjuvant therapy is a well-established protocol in rectal cancer, in gastric cancer, and also in borderline resectable and locally advanced pancreatic cancer. So, in the context of pancreatic cancer, a lot of pancreatic cancer resection patients after resection do not have adequate optimal performance status to complete their systemic therapy after surgery. And as we discussed that pancreatic cancer is a systemic disease right from the beginning, you always want to know the behavior of the tumor. So to allow a better biological selection, uh, the concept of neoadjuvant therapy is widely accepted in pancreatic cancer. So in borderline resectable and locally advanced pancreatic cancer, neoadjuvant therapy is almost considered standard of care. Now the clinicians or oncologists are arguing for neoadjuvant therapy even in resectable pancreatic cancers, as we know that only a radiological resectability does not mean that the patient has a good prognosis, and there may be bad prognostic sign in those patients, and therefore to allow to select out the patients who are likely to benefit with the systemic therapy. Only those patients probably will benefit with surgery, and therefore, neoadjuvant therapy allows better biological selection. There are better chances of therapy completion as I said, after a major surgery like pancreatic surgery, which is inherently associated with around 30 to 35% of major morbidity rate and around 5% or less morbid mortality rate, there are better chances of therapy completion with neoadjuvant therapy. In a significant proportion of these patients who complete successful neoadjuvant therapy, you can also achieve tumor downstaging, and early administration of systemic therapy probably will act on microscopic disease and give us a benefit of improved survival. Uh, I think should we directly discuss the evidence or so now the thing is there have been few studies. I don't want to go into these studies in detail. However, I would just try to mention them for the knowledge of the postgraduates. That the Alliance trial was a this was a trial which tested uh, neoadjuvant FOLFIRINOX with radiation therapy, and in which the addition of radiation to the neoadjuvant therapy failed to show survival benefit in borderline resectable pancreatic cancers. And that's why probably in neoadjuvant setting, whether we should give only chemotherapy or chemoradiotherapy, that question is still not answered. And currently, the role of radiation in the neoadjuvant setting is something which is questioned. Now there is another study like JASPAC 05, which compared surgery and adjuvant S1 with neoadjuvant chemotherapy and surgery followed by adjuvant S1, and this study gave some benefit of provided some benefit of neoadjuvant therapy in resectable and borderline resectable pancreatic cancer. And this is the most famous pre-OPANC trial, which tested around 246 patients of resectable and borderline resectable pancreatic cancer, where the benefit of neoadjuvant therapy was proven in borderline resectable pancreatic cancers, but the study failed to provide OS benefit in patients who had a resectable pancreatic cancer. So these are the few major studies which have been done in resectable and borderline resectable pancreatic cancers, where though there is no major evidence or a level one evidence in a lot of phase three randomized trials, there are a lot of phase two randomized trials which tend to suggest that in borderline resectable pancreatic cancers, probably there is a benefit of neoadjuvant therapy. And as we said that even without a high level phase 3 trial or a systemic review or meta-analysis evidence, surgeons and the clinical oncologists seem to have accepted the concept of um, neoadjuvant therapy in borderline resectable pancreatic cancer, because you want to give the benefit of surgery, or you want to offer surgery only in the patients who are likely to do well with systemic therapy. This is our experience of pancreatic cancer at TMH, where more than 200 patients received neoadjuvant intent chemotherapy. In our experience, the survival in borderline resectable pancreatic cancer with neoadjuvant or upfront surgery was similar on intention to treat analysis. However, the neoadjuvant therapy resulted in significant downstaging, R0 resection rate, and improved survival in the patients who undergo surgery after neoadjuvant therapy. So that's what we found out in our experience. So I think that covers the borderline resectable definition and the role of neoadjuvant therapy. In the patients who have locally advanced pancreatic cancer, nowadays there is a tendency to offer complete neoadjuvant therapy before surgery. As we said, that more than almost a third, one third of patients do not receive any adjuvant chemotherapy after major pancreatic surgery because of the comorbidity and because of associated with surgery. In locally advanced pancreatic cancer, there is tendency to complete as much possible neoadjuvant therapy as before surgery. So if the patient gets anything more than 6 cycles, that is called as defined as a total neoadjuvant therapy. Usually, in the context of borderline resectable pancreatic cancer, patients received 8 cycles of FOLFIRINOX if possible, or 8 cycles of GemCis nab-paclitaxel. And in the context of locally advanced pancreatic cancer, it is complete 6 months of neoadjuvant therapy with FOLFIRINOX if feasible. So there is a growing evidence that probably the total neoadjuvant therapy is the way to go if you are treating a locally advanced pancreatic cancers with the intent to downstage it to resectability. Uh, I think let's go to the surgical principles now. The most important surgical principle while approaching a pancreatic cancer is SMA first approach. So we know that the pancreatic cancers, because of the close proximity to the SMV and portal vein and the SMA, very frequently have abutments or involvement of these vessels, and therefore the levels of dissection around these vessels have been defined to achieve radicality when you are offering these surgeries to the pancreatic cancer patients. So I think I'll take you directly to the SMA first approach. and the concept of divestment. So the SMA first approach, classically, there are six approaches which are defined when you approach a pancreatic cancer. Please let me know when 10 minutes are remaining so that I can summarize and just focus on few important topics, because there is a lot to discuss, and I think we need to keep some time to for discussion with the students later. So classically, there are six SMA first approaches. The superior approach is from the triangle between the hepatic artery and the splenic artery on the portal vein. The anterior approach is directly at the lower part of the pancreas on the SMA and the superior mesenteric vein. The transmesocolic approach is the variation of an anterior approach where you go through the uh, mesocolon anteriorly, tend to take the branches of the middle colic artery and vein, and then approach the SMV and the superior mesenteric artery directly anteriorly. Um, a left posterior approach is something which is infracolic, which you do near the DJ flexor, where you approach the SMA from the left side. And the right medial approach is something where you retract the supramesenteric vein to the left side and then approach the uncinate process and the SMA directly from the right side. It is also called as uncinate first approach. And the most popular and the most common is the posterior approach, where you tend to approach the SMA at the origin. Uh, at the origin. So this is how the right posterior approach is. You can see that in the second image, the SMA, the duodenum has been completely cauterized. The interarticular area, IVC, and the left renal vein are in the vision, and the SMA origin has been exposed up to level 3 in the periadventitial area of the SMA. And this is the approach which you can start doing the surgery with this approach, because cauterization is usually the first step in the open Whipple procedure, and this is the area which you can dissect in the beginning of the surgery. So this is an example of right posterior approach. Almost 4 to 5 centimeters of proximal or the initial SMA can be dissected from here without any interference. The first IPDA usually appears around 3 to 4 centimeters from the origin, and 3 to 4 centimeter of SMA can be definitely dissected from here itself. So this is the right posterior approach, which is done for the tumors which are somewhere in the center of the SMA, or the middle part of the SMA, or the second part of the SMA, and this is the left posterior approach, where you can see that the SMA has been exposed from below. Can we mute those participants? Okay, Dr. Deepak Chavrai joined. Okay, sorry. Please unmute Dr. Deepak Chavra. I accidentally muted him. Okay. The second approach is the left posterior approach. You can see that the DJ flexure is in the vision. The SMA has been exposed from the left side, and this is the approach which is usually beneficial to the central tumors or the large uncinate
I'm
tumors.
unable to unmute Dr. Chabra. Could you do it yourself, sir?
I tried. Actually, the same happened here.
Not
Me
working.
try
I
again.
think I'm removing.
No, I'm okay. I'm okay. Let Vikram continue. Let Vikram continue.
Okay, okay.
I will intervene only if required.
Okay. The third approach is the mesenteric approach. Here you can see that this approach is for the tumors which are near the SMV, and in the third part of the SMA, which are near the branches of the SMA which go to the mesocolon and the middle colic artery. This is a very classical approach which is more popular in Japan, which is similar to an anterior approach, where the portal vein and the SMV is retracted to the right, and the SMA is approached directly anteriorly. Very frequently in this approach, you tend to take the branches of the SMA which go to the colon, that is the middle colic artery, or sometimes even the right colic artery. You take them at the origin and try to preserve the arcade to preserve the blood supply to the colon, and then go into the periadventitial as a plane to free the SMA. The SMA first approach has been controversial. A lot of surgeons felt that in resectable pancreatic cancer, probably there is no role for SMA first approach. There have been studies on SMA first approach. There have been randomized trials. Most of the studies tend to show that the SMA first approach results in less blood loss. The margin negative resection rate has not been different in SMA first approach, but for borderline resectable pancreatic cancers, SMA first approach, whether you are approaching the SMA first or not, assessing the operability on the preoperative scan, and then doing the level 3 periadventitial dissection for borderline tumors or locally advanced tumors is what is the standard of care currently, and that is what is to be followed. I think that takes care of the SMA first approach. Dr. Chavra, anything else you want me to add? Because there are a lot of information, but now I'm thinking how much and what information to give to the students. This is a classification which is proposed by ISGPS. So the type 1 is when you do not resect the vein, you just take a cuff of the vein, and maybe for a longitudinal transection, you close the vein horizontally, and that's the type 1 where you just do the venotomy and primary closure. The type 2 is somewhere where you use some kind of graft. A venoplasty is performed either with a native peritoneal patch or even an artificial patch. That's the type 2. Type 3 is the most common type of portal vein resection, which is performed in clinical practice, where end-to-end anastomosis between a portal vein and SMV, or SMV and a proximal portal vein, is what which is called as type 3. And type 4 is when you use the graft to reconstruct the portal vein. There are multiple approaches, ways of reconstructing it. The concepts which are evolving are in the pancreatic cancer. Locally advanced pancreatic cancer is the triangle clearance and divestment. Just a passing remark about divestment. So these are the levels of dissection around the artery. You can do a periadventitial or subadventitial dissection for a LV3 plane. And this is the need to approach in patients who have borderline resectable or locally advanced pancreatic cancer or resectable tumor which probably has abutment to the artery. So if you do a periadventitial dissection, en-bloc mesopancreatic resection with right hemicircumferential SMA dissection for invasive pancreatic head tumor is what is recommended for borderline resectable or locally advanced tumors. And this is a surgical technique which is likely to give you chances of more R0 resection and probably avoid an arterial resection and still achieve an R0 resection in pancreatic cancer, because arterial resections are associated with significantly high morbidity and mortality, and currently are not the standard of care. And that's about the divestment. Deepak, I have covered most of the principles.
Yeah, Vikram, if you can just highlight onto what the controversies are existing with the current scenarios of management of pancreatic cancers. No, just overall as a management of pancreatic, because I think for general surgical candidates, it is more of dwelling into controversies. What are the controversial topics in the pancreas? One is the type of anastomosis. Yes, you've covered that.
As far as the preoperative biliary drainage, so I told them there is no cutoff. There are few institutions which follow the cutoff of 15. However, the cutoff is more for associated malnutrition and coagulopathy and liver dysfunction rather than absolute bilirubin levels. The evidence has been in favor and against doing a biliary, both in doing a preoperative drainage in patients who have bilirubin levels more than 15. But for all practical purposes, the patients who have bilirubin less than 15 do not need preoperative drainage if they do not have associated.
Vikram, I think let's take it one by one. I know you've summed up most of the things there. Let's give them a sum up of everything. Preoperatively, CT scan versus MRI scan versus PET scan. If we have to tell you that all three, only two, any two, which one would you recommend the students to answer in the Viva exam?
Yes. So I have already explained to them what is a pancreatic protocol CT scan. The cross section in the cross sectional imaging, pancreatic protocol triple phase CT scan is the investigation of choice for evaluation of pancreatic cancer, whether it is resectable or borderline resectable locally advanced. This is the type of imaging which is most commonly used. MRI, if you have a good quality MRI, the same pancreatic protocol MRI can give you the exactly similar information and has the exactly similar utility. However, because surgeons are more used to evaluation and reading of CT scans, and because they are more familiar with CT scans, cross-sectional imaging, triple phase CT scan is the preferred imaging. As far as role of PET scan is concerned in evaluation of pancreatic cancer, it is not recommended as a standard of care. Having said that, in patients with locally advanced pancreatic cancers and patients with borderline resectable tumors, or the patients who have significantly raised CA19-9 levels, there has been an argument for selective use of PET scan. It is not a recommendation, but some clinicians and centers use it in this context. But PET scan is not a standard of care in pancreatic cancer. A newer PET scan, which is called as a FAPI PET, is coming up, and it is being selectively used because it has a very high sensitivity in pancreatic cancer. But currently, its role, if you ask me in clinical practice, is limited by its availability, and the role is not defined. But in patients who follow up after surgery, in situation where you need to evaluate or document the recurrence, that is also one of the indication for a PET scan. So PET scan is not a standard of care. It's not a recommendation. It is used selectively by a few clinicians, but it is not a standard of care, is what I would say. Anything else I need to clear on this, Dr. Deepak?
No, that's fine. I think I just wanted you to sum up one by one that preoperative investigative modality is triphasic PET CT. Preoperative bilirubin is no bar in high volume centers where people even with bilirubin of 15 will go ahead and operate. Whereas some centers, especially the medical colleges where the students are studying, they may be finding patients who have been stented even at bilirubin levels of 2 and 3, where they are not sure of what is going to be the course of these patients and where they are going to take a treatment from. And a prolonged bilirubin in these cases may hinder a surgical outcome.
Agreed. So I think for students, it is important to know that absolute indications are cholangitis, coagulopathy, need for neoadjuvant therapy, and significant malnutrition. The relative indications can be anything, but I don't think that we should discuss here. The student should know that the absolute indications are these. Anything else is not a standard.
Yes, the third portion which Vikram did cover again was the biopsy. Biopsy diagnosis, not an absolute necessity, correct?
Yes. So as far as the CT scan is showing you a clear lesion in the pancreatic head, which is resectable, or a periampullary lesion, which is resectable, at least in pancreatic and periampullary cancers, biopsy and lesion documentation, again on endoscopy or endoscopic ultrasound, is not a must. So in resectable tumors with obstructive jaundice, you can go ahead and operate them. However, if, as I said, there are a lot of patients with periampullary tumors where you will fail to document a lesion on the CT scan because some of the lesions are exactly on the ampulla. They are less than 2 centimeters. It is difficult to differentiate between actual ampulla and the tumor on the CT. Some of the small distal cholangiocarcinomas maybe just appear as thickening of the bile duct. In those patients, probably you need to document the lesion at least, if not biopsy. And probably in those patients, you need to attempt side view endoscopy or endoscopic ultrasound or FNAB selectively. But it is not a must in a patient with obstructive jaundice with a documented lesion on a scan to do a biopsy or document the lesion any further. And these patients can be offered surgery with that much evidence only. However, any patient who needs systemic therapy, you need to have a tissue diagnosis. So therefore, all patients who are borderline resectable or locally advanced, or all patients who have metastatic disease need to have a biopsy. In metastatic diseases, you will biopsy the site which is most commonly accessible to you, and you need not actually go for a biopsy from the primary site. Dr. Deepak, anything else you want me to?
So post-operative management, Vikram, most of the patients, most of these people, students will, some of them are MS, some of them are DNB, they have post-operative rounds. Now, in the post-operative round, sometimes you have a Whipple's patient who's been operated. Some patients have an NJ, some patients have a feeding J. Of course, when you see a lot of medical colleges now are still practicing the use of feeding jejunostomy tubes, what should be the students' answers to the professors when they ask about the post-operative management of patients who have been operated for Whipple's?
I think as far as the nutrition is concerned, the pancreaticoduodenectomy is associated with a significant delayed gastric emptying rate. The delayed gastric emptying rates are actually not documented well. They are slightly higher than what you actually, in clinical practice, they are slightly higher than what you actually see. And therefore, some form of enteral nutrition access is important. A lot of centers perform feeding jejunostomy with pancreatic duodenectomy. At least at Tata Memorial, we do not perform a feeding jejunostomy. But in a significant proportion of our patients who undergo Whipple procedure, we tend to put a nasojejunal tube for early feeding after Whipple procedure. Early feeding with nasojejunal tube, also there have been reports or studies which probably suggest that starting on oral feeds early than nasojejunal feeds is better as far as recovery from delayed gastric emptying is concerned. However, for all practical purposes, the patients do well if you have a nasojejunal tube as a backup plan if the patients develop a prolonged delayed gastric emptying. So our protocol is to use a nasojejunal tube, and we use it for feeding if the patient's delayed gastric emptying does not allow that patient to take orally in first 4 days. So probably by day 4, day 5, if the patient is not able to take orally, if the patient has a higher rise to aspirate, or if the patient has intermittent vomiting, we would consider starting nasojejunal tube feeding after day 3, day 4.
Right.
Feeding
And if the
jejunostomy,
okay.
yes, feeding jejunostomy. Uh, if the center is performing that, you can start feeding as early as day 1. Start with a small dose of around 20 ml trial feeds and gradually increase that. Having said that, feeding jejunostomy is also a procedure which can result in complications, and uh, and uh, it is associated with complication rate as much as 25 to 30%. And that is one of the reasons why we have given up doing that. And many surgeons who used to do it routinely for esophageal cancer or total gastrectomy also have actually now resorted to nasojejunal tube. So feeding jejunostomy as a post-operative nutritional access procedure is losing its favor among the surgeons.
Yeah, having said that, most of the medical colleges, I don't think they are still having enough number of nasojejunal tube. It's difficult logistically for them to procure fracas tube, especially when they have a medical college and they have a high volume center with the medical college. It becomes difficult. So I think feeding jejunostomy tubes are still common in various parts of India.
Yes,
Despite being on the
yes,
literature, yeah, we still have people. So I think feeding jejunostomy becomes
so,
important.
yes, I will say that some sort of nutritional access, enteral nutritional access is desirable. So I will not say that feeding jejunostomy should not be done. If the center does not do nasojejunal tube placement, feeding jejunostomy is a completely acceptable process. I completely agree with you.
Yeah. Okay. Now the drain suddenly in the post-operative rounds turns turbid. Do you place drains in every patient in the sense sometimes you may place 2 drains on either side, sometimes no drain, sometimes drains. Now suppose you see that there is a right-sided drain which is clear, serous, and the left-sided drain which is turbid. How do you manage such patients?
So the so the drain, a turbid drain post-operative period is probably suggesting a leak to you.
Yes, probably suggesting a leak.
थोड़ी देर में फोन करता हूँ. Just a minute, Dr. Deepak. Yes, sir. Sorry. So a post-operative turbid drain is probably suggesting you that patient is probably developing an anastomotic leak, and it should make you more vigilant about the patient's recovery in the post-op period. If that leak, that color is associated with raised fluid amylase levels, it is probably proving you that the anastomosis has leaked. The patient's clinical status at that time is important. A few of these clinical leaks may turn out to be biochemical leaks, or even if they are mildly infected, they may resolve on itself over a period of time. But once you see turbid fluid in the left drain, or in the drain which is around the pancreas, or any drain for that matter after the Whipple procedure, you should be aware that this patient probably needs more care, more vigilance, and you should be focused now on the patient who is probably likely to develop a POPF. The management will depend upon patient's clinical situation at that time, along with the color in the drain.
Correct. I think with that, Vikram, we have covered most of the things that is needed for at least at the undergraduate and the postgraduate level for these people. If there are any pressing questions from any of the people attending the meeting, I think we will be happy to answer that.
I was actually confused. My problem was I didn't know what to cover and what not to cover.
No, I agree with you. I think pancreatic cancer itself is a difficult. Pancreatic cancer itself is a difficult situation. The topics can turn very differently. Say for example, in the post-operative ward rounds, you may start with a post-Whipple patient, but it can completely go on the nutritional status and the nutritional assessment anthropometric measure. So I think students have to be in general prepared with everything, but not forgetting the original topic where they started from. I think the topics are just a start of to evaluate the students as a whole.
I agree. Another thing is maybe we can show them a surgical technique of approaching a borderline resectable SMA first approach or something like that.
No, that will be too much for those people. Borderline first, I think if you can show them a normal Whipple, a routine, a simple Whipple as to what is the portal tunneling, how is the gastrohepatic, I think that is more important for them rather than having to deal with difficult cases of borderline.
I don't know. I'll just check if I have a video of that.
Yeah. How much time do we have now? How much time
just take the questions otherwise.
Yeah. How much time do we have more? I think we have.
I think we have. No, it's already 4 actually.
Yeah.
Can somebody from Jaipur tell us what exactly, like, do we have some time or like?
This is Dr. Desai. I don't think either Piyush Varshney or Dr. Anand are here. Professor V.K. Kapoor also has not come.
No,
we end up with some case. So I think if there are topics to be covered, we can take 5 more minutes.
Yeah, I think so.
Desai, anything you suggest us to cover apart from that? So this is, I think, just a small clip on the SMA first approach where you can see the anterior.
How do you deal with frail patients? Do you assess frailty at all?
Yes, I think the subjective global assessment of the patients in the preoperative period is very important. The frailty is associated with significant rate of perioperative morbidity in pancreatic cancer, surgery after pancreatic cancer, and it needs an important it is an important factor to assess in the preoperative period. Most of these patients will need rehabilitation or prehabilitation before surgery. And unless they are assessed to be fit to undergo surgery, you should be very vigilant in offering them surgery. Yes, frailty is an important assessment factor in preoperative phase, and these patients need a significant rehabilitation. We have a protocol where each and every patient undergoes a nutrition rehabilitation at least for 3 to 4 weeks. These patients are advised to meet a physiotherapist at the beginning. Most of them have learned their spirometry before for 2 to 3 weeks before they come on table. Most of them are on high protein diet quite from their diagnosis till the surgery. And all patients who have 70 years and above, all the patients who have ASA3 status, they go for a clear tumor board meeting even with the anesthesia team. We call it a high risk JC, where a joint tumor board meeting is done with the anesthesia team, where their overall general assessment and the risk of complications in the perioperative period are assessed, and these patients are sent for rehabilitation. So that's what we do here. Anything else you wanted to suggest?
I think you covered everything. So
Yes. But apart from that, if you're operating a patient who is an octogenarian, you have to be extremely careful. Uh, uh, as the incidence of pancreatic cancer is increasing, the more and more patients who probably may be resectable or borderline resectable, who are above 75 are detected. At least in our experience, patients who are less than 80, um, they can be offered surgery as long as they are fit to undergo surgery as per pre-operative assessment. Above 80, you have to be extremely vigilant in offering pancreatic duodenectomy, and these patients really need to be less than 80 as far as their biological age is concerned than the real age, and then only probably we will offer surgery. So above 80, we are vigilant. Less than 80, it's as per patient's performance status. So I think that was a small video on SMA first approach. I do not have standard video of a open Whipple, but I think I have a video of a robotic Whipple, which is the standard procedure, not a portal vein resection, not a SMA first approach. I don't know if that can be shown.
No, I think we won't have that much of time to cover up everything. I think if there are not any pressing questions, then
Are there any questions? Yes, if there are any. Contact with IVC, how to define, sir, borderline resectable or unresectable? Yes. I think the involvement of IVC has been defined as a locally advanced lesion tumor in pancreatic cancer. Whether they are right-sided or left-sided, in both situations, involvement of the IVC or a significant abutment of contact of IVC is a definition of local advancement.
what is your policy in multi-organ resection for pancreatic cancer, like hepatic flexure of the colon, more of the stomach, in those
Yes,
lines?
so we have published our results of extended resections in pancreatic cancers, and I think they should be done at high volume centers. But when indicated, multivessel resection or an extended pancreatectomy is something which can be offered now. As I said, at high volume centers, the morbidity is around 25 to 30%. But most importantly, most high volume centers would have mortality which is less than 5%, and nowadays maybe near 2 to 3%. And in that sense, providing them the benefit of R0 resection, even if you have to offer a multivessel resection, is justified, is what I would say. Our experience suggests the same. 5 years back, we published our extended resection experience of around 70 resections. Now we are in the process of publishing our extended resection experience of around 170 cases. I would say that in our experience, offering an extended resection in well-selected patient at high volume center is something which should be a routine.
Yeah, there's a question in chat. What is level 1, 2, and 3 divestment? Give us a small idea, sir.
Yeah, just a minute. Sorry. So, hello, can you hear me?
Yes, we can hear you.
Just a minute. Somebody is at the door. So, this divestment is something which was proposed by Dr. Ino's group, which was proposed by defined properly by Dr. Ino's group from Japan. I think it was defined by a Chinese group, Yi Miao and their center. So there are 3 levels of dissection around the SMA. Level 1. So these are the dissection levels of systematic mesopancreas dissection, SMD, and the levels are defined as level 1, LV1, LV2, and LV3. The level 1 is a normal dissection which just takes care of the nodes around the SMA, and it does not actually go into any periadventitial plane. And that is a standard which can be used only in few patients who have benign pancreatic tumors. So if your indication is a neuroendocrine tumor, or if your indication is a periampullary tumor which does not seem to have any involvement of nodes, these are the patients where you can go into a normal peri-SMA plane where you are not taking any periadventitial tissue or a neurolymphatic structures which are around the SMA. That is level 1. Level 2 is a type of systematic mesopancreas dissection where you take partial level 3 dissection. So it is like going in the periadventitial plane, but you do not do 360 dissection around the SMA. Level 3 systematic mesopancreas dissection is a classic divestment procedure, which you tend to do for patients who have borderline locally advanced tumors. And this is the technique which has been generated to avoid the arterial resections and still try and achieve R0 resection in pancreatic cancer. Because as we know that arterial resection are associated with significant morbidity and mortality, and they are not considered standard of care in pancreatic surgery. So level 3 SMD is called as divestment. Again, in level 3 dissection, the adventitial divestment and subadventitial divestment, which go either into the subadventitial area or periadventitial area of the artery of the SMA. If you are thinking of offering divestment to the procedure, the team should be prepared to do the resection at all times, because when you are doing an extensive divestment, these patients sometimes may need a resection and you need to be prepared to do one if it is required. I think that should be more than enough. There was a question on renal dysfunction. Huh?
No, I can't see anything in the chat, but it's probably a topic that you could cover.
If there is a renal dysfunction, then can we do perioperative? Yes. I think a jaundice, which is associated with significant hepatic dysfunction, which probably sometimes will also result in renal dysfunction. Like if the patient has a significantly raised bilirubin levels, a patient has a clinical dehydration, and then the patient has a pre-renal renal dysfunction. These patients will also need that, but probably they need to be hydrated. Their coagulopathy needs to be corrected, and then they need to undergo perioperative biliary drainage. Yes, it would be an indication for perioperative biliary drainage.
So I think we should sum it up now.
Yes, I think I'm done. If there are questions, then it's okay. Otherwise, we are done.
Yeah, I think we are 10 minutes over time. So
yes, thank you. Thank you.
Yeah, I think that was a very comprehensive
Thank you, everybody.
Thank you. Thank you very much. Thank you for all those who are attending, and thank you, the JSS Society, for having this. Thank you.
Thank you very much. I hope the students who have participated have benefited because I was really confused what to cover and what not to cover. But I hope we have given them the message about overall management of pancreatic cancer and at least introduced them to the terms of borderline dissectability and local advancement and neoadjuvant therapy and divestment and levels of dissection around pancreas. I think and the SMFS approach. So I think they have heard everything, and if they read, I think it should be okay. Thank you.
Thank you, sir. Thank you very much.
Thank you, Vikram, once again. Thank you all.
Thank you, Dr. Dilip.
Thank you.